Thank you very much, Dr. Banco, for your introduction. And I know that talking on Monday afternoon, it will be a little bit difficult because a lot of us has to move and go back home. My objective is to give you some ideas about what is really important in staging the laryngeal cancer. I will not cover the aspect of the lymph nodes, but I will mostly narrow the discussion in the local extent of the lesion. About epidemiology, laryngeal cancer are the second most common malignancy of the upper aerodigestive disease. Mostly they develop in the male patient, 90% in patients older than 40 years old, and approximately 85 to 95% are squamous cell carcinoma, more than half arising in the glottic area, and 40% about in the supraglottic area, and a very few of them from the subglottis. And they can be suspected because of the hoarseness. In this case, for the hoarseness or the presence of concomitant neck mass, the patient is going to have laryngoscopy. If the hoarseness is not associated with any other symptom or associated to a high-risk finding, usually it should be evaluated after 3 months without disappearing, and or if irrespectively of the duration, you have an history of tobacco or a mass in the neck or hemoptysis and so on, then in this case the patient will have, first of all, laryngoscopy that will be done with a flexible laryngoscope. It is also possible to cope this with a stroboscopy that will give you information about the movement and the movement of the true vocal cord, and also it is possible to associate this type of evaluation with a special filter that will provide you information about the presence of abnormal vascularization of the mucosa. This is the narrowband imaging. If the patient is going to be treated at that time, intraoperative rigid microlaryngoscopy with different degrees of the optics will give you information regarding the state of the anterior commissure, the state of the ventricle, or it is also possible with a 120 degrees of optic to see the inferior surface of the true vocal cord from below. At the end of this process, not the intraoperative, but at the end of this process of clinical diagnosis, you can have a situation in which you are knowing that the patient has vocal cord paralysis, but without any lesion in the larynx, or you are dealing with benign or malignant lesions. It is very important to underline the implication of the accuracy of the imaging test, because treatment decisions are related to the precise clinical extent of cancer spread inside or outside the larynx. And this is the most critical factor in localized early to intermediate laryngeal cancer. And then another point is that the success of partial laryngeal surgical procedures, such as the open procedures or the endoscopic laser-assisted techniques, in the last decades led to a significant increase in function sparing, and therefore function of the larynx is very important, but also partial laryngectomies were able to remove the lesion in early to even more directly advanced cancer. Finally, the introduction of combined chemoradiotherapy resulted as an efficient alternative to the total laryngectomy, and this is an organ-preserving approach widely adopted for stage 3 and stage 4 lesions. According to the NCCN guidelines 2013, when you have a glottic cancer or a supraglottic cancer, it doesn't change. The workup will include, apart from the biopsy, imaging to exclude the metastasis or secondary or concomitant simultaneous tumor in the lung, And the evaluation of the local extent and also nodal disease can be done using CT or MRI. And in advanced lesion, we have to consider the use of PET-CT to exclude the presence of distant metastasis mostly, or simultaneous other tumor. This is a phrase from Lefebvre that underlines the fact that the larynx preservation is one of the major changes in the last decades for the treatment of the laryngeal cancer. And there are different ways to achieve this goal. And probably we didn't end to develop the proper solution to preserve the larynx and treat the patient. But basically, there are two different ways. The first way is to go for the non-surgical approach, will have among its weapons the radiation therapy alone or combined with chemotherapy. And then, as I already mentioned, the surgical approaches, which can be done through entirely by the endoscopic approach, or in the next future, probably also with robotic surgery, or open approaches that will spare the function of the larynx, like the horizontal supraglottic laryngectomy in case of supraglottic tumor, or the different supracricoid laryngectomies for either supraglottic and glottic tumors. Of course, this list should be, or could be, longer, but I decided to include only a couple of the most frequently used techniques. Therefore, I can sum up the validated option to preserve the laryngeal function, as I already mentioned, but we have to take into consideration also the fact that when it is not possible, we have radical surgery, which remains indicated as an initial treatment for advanced cancer, particularly for T4 lesions, or a salvage surgery after the failure of radiation therapy or chemoradiation, or the failure or other open or endolaryngeal laser procedure. This is very important, and I am part of a multidisciplinary board that will discuss the cases to select the best option. The key points when you are dealing with the tumor arising, for example, in the glottic cancer, which is the first topic I would like to address, is that you have to analyze, as a radiologist, the relationship of the tumor with the laryngeal framework. I mean, the thyroid lamina, the cricoid lamina, and the arytenoid cartilage on top of the cricoid cartilage. You have to identify and grade the extent inside the preepiglottic space or inside the paraglottic space, taking into account the fact that paraglottic space is a fat space without any boundary between in the vertical path, but it is very narrow depending on the habit of the patient, very thin, obese patient, but also for this reason it is very difficult to analyze the area where you have the ventricle very close and part of the true vocal cord very close to the thyroid cartilage, which is surrounded by the perichondrium. And you know very well that the thyroid cartilage will be a barrier to the invasion if you have a non-ossified cartilage, whereas for ossified cartilage it's easier for the tumor to spread through the cartilage itself. Therefore, there are different types of path of spreads. From the glottic area, you can have a tumor arising inside the preepiglottic space through the petiole, submucosally spreading, or invading the thyroid cartilage at this level, which is the anterior commissure. We will address this point. Or going downward below the anterior commissure and reaching the area where you have just a connective fascia, which is the fascia between the thyroid cartilage and the cricoid cartilage, that can be this membrane invaded by the tumor. The lateral extent of the vocal cord tumor is in two different directions. One is the inferior paraglottic space, and this is a way the tumor can use to go outside the larynx being unnoticed, because there will be impaired movement of the true vocal cord or cord fixation, but the tumor can be submucosally spreading outside the larynx through this part, through this path of extent. The other point I will not address, but it is the point of the metastasis. Well, metastases are related to the different embryologic origin of the larynx. The upper part, the supraglottis, is arising from the third and the fourth branchial arches. It is a buccopharyngeal anglage, and this accounts for the fact that you have a very developed network of lymphatics at that level, whereas the network of lymphatics in the glottic area, which arises from the fifth branchial arch, is definitely less dense than the one in the supraglottis. And then the network are not completely connected. So the chance of having metastasis for the same size of tumor in the supraglottis is definitely higher, greater when compared to the glottic area, number one. Number two, it is very important to consider if you are dealing with a tumor on the lateral part of the supraglottis or in the midline, because tumor in the midline, of course, in the midline, they can spread their metastasis on both sides. What to say at this moment? I'm not a surgeon, but this is the path that usually is adopted in several centers. If you have a primary head and neck squamous cell carcinoma, in this case in the larynx, clinical examination, the presence of a node can be detected by clinical examination, or the clinical examination can be negative. We usually combine the clinical examination with the ultrasound, if necessary with fine needle aspiration cytology, and if it is negative and the risk due to statistics is greater than 20%, the patient, even if the fine needle aspiration cytology and ultrasound are negative, will have elective neck dissection. Otherwise, if the risk, statistical risk, according to the side and the T extent of the tumor is lesser than 20%, usually the patient will not have a diagnostic neck dissection, but will have a follow-up. Early glottic cancer. The results, the outcome of transoral laryngeal laser surgery and radiation therapy are very close, up to 85 to 100% of local control. And also in level 3 of evidence studies, it is clear that if you put radiation therapy versus laser treatment, there is no difference. And then there could be also discussion about the quality of voice, but this is not the point at the moment. What is very important is to understand that if we have to make our examination and to report the findings about the local extent of the tumor, there are key structures that will influence the decision treatment. I try to sum up these structures for the selection of radiation plus or not chemotherapy, laser resection, and supracricoid laryngectomy. The involvement of the anterior commissure is not a contraindication for radiation therapy. It is controversial. Some in the literature have very good, serious. Others say that this will increase the chance of not controlling the tumor, but this is not at all a problem for supracricoid laryngectomy, because in this type of surgery, it will be removed. Posterior commissure is not a problem for radiation therapy. It is for laser resection. It is for supracricoid laryngectomy. Therefore, the tumor that invade this part of the larynx behind at the end of the lateral part of the cord, it is a contraindication for these two surgical approaches. It is controversial, the involvement of the membrane for the laser resection. It is not for supracricoid. The posterior and the inferior paraglottic spaces, they are not a contraindication for radiation therapy and chemotherapy, but in this case, probably that there is involvement, there is impairment of the movement of the cord or fixation of the cricoid-retinoid joint. They are a contraindication for surgery. And then we have the problem of the thoracic cartilage. We will see also this problem will be addressed further on. But you know that the minor invasion of the cartilage, it is a contraindication to laser. It is not for the supracricoid cartilage. And for the supracricoid laryngectomy, T4A is controversial. You can remove it if it is in front, in the midline. You cannot remove with a low risk if you have involvement of the lateral lamina. Then we will see all the other points. Therefore, this is the flow chart. Endoscopy and BI, if you suspect that it's just a superficial lesion, you can go to translaser or radiation therapy. If you suspect a deep extent, this is CT ruling the rest of the decision. No deep spread on CT, again, transoral laser surgery or radiation therapy. If you have involvement of the paraglottic space, if it is the posterior paraglottic space, you cannot treat the patient with a supracricoid laryngectomy. If it is the anterior space, you can do. If you have minor or greater involvement of the thyroid cartilage, you have to switch from, you have also to consider for the minor involvement of the radiation therapy. If the tumor is invading the mucosa on top of the arytenoid cartilage, just one, you can remove it and remove the cartilage. If you have both of the mucosa investing the cartilage invaded, you have to switch to a total laryngectomy, also in case of cricoid invasion. So this is the path. The anterior commissure is very important because you don't have any perichondrium. You have absence of the barriers, early ossification at this level. It cannot, if the tumor is invaded this area, the vocal cord can move normally. But if you have tumor approaching the anterior commissure and impaired mobility, this is a major risk factor for cartilage invasion at this level, statistically speaking. And it can be very difficult for laser in some patients to expose because of the neck, the patient to treat this area. The criteria proposed by Barbosa in 2005 are related to the thickness of the mucosa at this level. So you know that you have directly CT, very thin mucosa over there. This is a patient already treated by radiation therapy. This is the scar in the piriform sinus area. And you see that the thickness of the mucosa is it is normal in this case, and it is abnormal in this patient. I put a red arrow to show where is the thickening of the mucosa. The criteria proposed by Barbosa are more than one slice, 2, thicker than 1 millimeter at this level, or the tumor growing inside the preepiglottic space, like in this situation, or down or inside the thyroid cartilage or down to the cricoid cartilage. In this patient, we know clearly that the thickness of the anterior commissure is beyond the normal appearance. And we also can see where the tumor is extending downward from the true vocal cord. And then we can start seeing a sign that is not so clearly described in the literature for CT, which is the edema at the level of the inferior paraglottic space on the right side, a sign that I started to understand after doing MRI. An example for MRI, same level, thickness greater than 1 millimeter, at this level with different T2, T1, post-gadolinium gradientico and standard T1 post-gadolinium. The paraglottic space that was very close to this area is really very narrow anteriorly, and it is larger posteriorly. The paraglottic space is very important. It is very difficult to assess the invasion of the anterior paraglottic space for the findings, for the reason that I already mentioned. The anterior paraglottic space extremely thin, the posterior paraglottic space larger. But this area is critical for the tumor to grow inside the inferior paraglottic space and outside the larynx, or for the fixation of the arytenoid cartilage. Take into account the fact that this is not at all the vocalis muscle. This is the lateral cricoarytenoid muscle at this level. And here you have the mucosa investing the piriform sinus, so close to the larynx, and the cartilage is there. So it is thicker. We have to check if the tumor is invading this area or not. This is one example. The tumor is in the anterior paraglottic space. Patient had these problems, and this as a first initial negative examination that a true vocal cord was suspected. You see the contrast agent, you see the diffusion-weighted imaging. In this case, this is B1000, very high signal, and this is the restriction at that level, and also edema on the opposite side. Well, if you do this using 2 millimeter and isotropic sequences, it is possible also to overlap and have a fused information, and also a reconstruction of the diffusion-weighted imaging in the coronal plane, and to separate the restriction for the edema surrounding the restriction. And when you do this, probably this is something that could be quite useful, as you can see, quite useful to discriminate edema from real tumor invasion. If you retrospectively see the CT on the coronal plane, you see that this is an area where you have muscular density, this is an area where you don't have muscular density, but the density is different from the tumor. And then the fat is partially replaced lateral to the true vocal cord, and everything is already there in the MRI. This is another example, the invasion of the true vocal or the anterior commissure, but in this case, that is also an example of the edema at the level of the posterior paraglottic space that is there. Tumor is not invading the cartilage, but tumor has also a fixation. There is the invasion of the paraglottic space, and in this case, you don't see the muscle, you see the edema on the other side, and the patient had a supracricoid partial laryngectomy. Well, now we move to the area of the thyroid cartilage. T3 is not a contraindication for radiation therapy or for supracricoid laryngectomy. As you can see, when you do supracricoid laryngectomy, you remove the whole thyroid cartilage, you leave the iode and the cricoid, and you fix them together, therefore shortening the vertical accent of the larynx. The extralaryngeal spread, it is a contraindication for radiation therapy and also for the laser, if in the anterior part, not for supracricoid. And then the mucosa investing in the arytenoid is very important, as already mentioned, and of course, the invasion of the cricoid cartilage is a contraindication. Which are our criteria? Sclerosis, erosion, lysis, and extralaryngeal spread. The problem is that in the last decade, several papers came out showing that there are some problems using CT, and using CT, we can have overstaging of the invasion, and the positive predictive value can be something like 60%, and the negative predictive value is always better than the positive predictive value, according to this experience in 60 patients. And also we will see again this paper in patients that underwent total laryngectomy. The local control was not really associated to the presence of the minor cartilage invasion. We will see this. And the very big problem is the fact that if those patients who had total laryngectomy, the rate of thyroid cartilage penetration were up to 78%, and in this case, again, the fact that the tumor invaded the cartilage was not a great problem for the result of the outcome of the treatment. And up to the same group, up to 59% of thyroid cartilage penetration of this, fewer demonstrated by CT. So CT demonstrated, when compared to pathology, only 60% of the invasion. And when the CT said that there was invasion, it was confirmed only in 73%. So this is a problem because at the end, the consideration is that CT was not sensitive, and the extralaryngeal accent was confirmed in 80% of cases. Therefore, this is the overall question about the use of CT, whereas for MRI, the development of new criteria can add something else, as we know. And these criteria were basically, we have to check if the signal of the tumor is the signal you have inside the cartilage, improved the specificity up to 82% from 74, and this criteria worked very correctly mostly for the invasion of the thyroid cartilage. And the sensitivity was not changed by the application of these criteria. Of course, if you have a situation like this, it is possible with CT, easy, I should say, even if it is completely submucosal spread. If you have a situation like this, you have a question about, because the tumor is on the right and you have a defect on the left, the defect has no signal pointing to the different signal detected by using T1, T2, gradient echo, post-contrast, and the combination of B0, B1000, and the ADC map. So no invasion of the cartilage, even if it is not totally ossified at that level. Or if you look at the signal which is bright on T2 in the thyroid lamina, it is hypo on T1. This can be possible with tumor or can be possible with edema, and this is definitely bright on the ADC, bright on B1000, so it's consistent with the inflammation and edema at this level. Of course, there are situations in which you are not sure. This is one I remember very well, and in this case, at the end, because the decision was for supracricoid or not, we did this through the fine needle aspiration cytology, ultrasound guided. This criteria can work in the patient, so we try to add MRI in patients to increase the possibility of exploring the signal inside the larynx and also inside the cartilage. This is the tumor. As you can see, you can separate the lateral cricoarytenoid muscle from the true vocal cord, so its signal is different from the signal of the true vocal cord invaded by the tumor. You can pick up the difference between tumor and edema, and also the tumor spreading on T1, but also on the B1000 inside the cartilage. And this is tumor and the edema on the panel of the different approaches. This patient, which is again this one, underwent chemoradiation therapy, and at the end we had still tumor over there. And if you compare the cartilage on the left and the cartilage on the right, the hypointense signal, meaning the restriction is over there, even if after radiation therapy, the restriction parameter and map will change. What about, linked to this last case, what about the non-surgical? Because we saw mostly the finding that will change the approach for the surgical treatment. Non-surgical approach and the information that will guide the treatment. Well, there is a very long group of papers in the literature, there is also Ljumanovic, that demonstrated that the tumor volume and the cartilage invasion are prognostic factor for efficacious treatment of the primary squamous cell carcinoma. The discussion is cutoff level of the tumor volume and the repeatability of the evaluation of the assessment of the deep spread. Well, it is clear, according to this correlation between the mean gross tumor volume prior to radiation therapy and the evidence of the cartilage penetration, the greater the laryngeal volume, the higher the rate of thyroid cartilage penetration. So that the oncologist, the radiation oncologist, knows that particularly for the supraglottic, but also for the glottic, if the tumor is large, then the chance of having involvement of the cartilage is higher. But this is one of the papers I tried to show before. This is a recent assessment in the literature where they compare the patient treated by radiation therapy for T3, T4, and no cartilage invasion for this part of the cohort, and the local control was 80%, and the laryngeal free survival was 16%. In patient with thyrocartilage invasion, also in patient with cricoid, small, only 2, but thyroid and cricoid invasion, they had a local control for T3 of 86%, so no difference, but for T4, 55%. They had a subset of several patients in which there was, they claimed, invasion outside the larynx without thyroid cartilage. This is an example of how the volume factor can affect the overall survival in patients with small glottic carcinoma treated with radiation therapy. As you can see, the greater is the volume and lesser is the control of patient. But surprisingly, this is a very recent paper regarding the fact that chemoradiation therapy has become the paradigm for patients with advanced tumor, T4-8. This is a review of 384 patients where at the end the findings that they underlined were if you start with surgery and not with chemoradiation therapy, the disease-specific survival is better in those patients. And the prognosis is affected, as we already know, by the end status in the neck and by, if you're doing surgery, by the R status. So R0 means no residual tumor versus positive residual tumor. So this is one interesting point. Finally, I have 30 seconds. For the supraglottic cancer, it is the vertical extent in the vertical direction toward the base of the tongue, toward the glottic level. We compare, in this case, a supraglottic arising from the inferior part of the epiglottis and directly involving the area of the glottic on both sides. Again, edema you can see. Now you understand what is edema. In this case, we were correct in assessing the involvement of the true vocal cord because it was involved anteriorly. Instead, in the intermediate position, there was mostly edema, and you see that the cord is displaced medially. But we were not correct for the invasion of the thyroid cartilage, either on CT or MRI, because there was a minor T3 invasion, which is always observed when you have a transglottic tumor arising from the supraglottis, not a supraglottic tumor limited to the supraglottis. This is a similar approach, but the tumor stops there, and then you see mostly the edema of the true vocal cord level and also the subglottic area. The other point is that MRI can also be used to assess the potential invasion of the membrane between the thyroid and the hyoid, which is not invaded in this case. And also, edema is something we learned to appreciate that can help us to understand what we have at the level of the true vocal cord. So to sum up, the radiologists need to understand the following issues. For the supraglottic tumor, it is the transglottic extent that is very important. Usually, you have the thyroid cartilage involvement when you have a real transglottic tumor. Tongue-based involvement is minor, can be addressed with several approaches. Glottic tumor, thyroid cartilage invasion, full thickness is T4, cortex only is T3. The pattern of invasion are related to the involvement of the paraglottic space or anterior commissure extent. And the degree of involvement of the true contralateral cord is also something that can be assessed, and also the degree of the subglottic extent. Thank you very much for your attention, and sorry for the 3 extra minutes.